So our next speaker is Dr. Mohan Rajan. And Dr. Mohan is going to speak on after PCR, what next?
Thank you, RP, and let me again thank the AOS for this wonderful opportunity of being here. It's always a pleasure to coming back to see. Anticipate PCR when you have traumatic cataract, cataract post-vitrectomy, posterior polar cataract, hard-bound cataract, pseudo-exfoliation, and nowadays we have patients who got multiple injections into the vitreous cavity. We have to anticipate PCR. It's called touch cataract. So stages at which the PCR can occur, any stage for matter, but more commonly during the what you call the cortex removal, because a high vacuum is used and the posterior capsule is not protected as well. So complications, suppose you don't use treat the PCR properly, you can have endophthalmitis, you can have secondary glaucoma, you can have corneal decompensation. All these problems can occur, and you don't want to have that. One of the most important things is when you have a PCR, okay, see this, what is happening. So when you have a PCR, you get jittery, you may be operating on a VAP or a doctor. So what is important is not to pull out of the eye. Do not pull out of the eye. If you pull out of the eye, what will happen is, what is a small PCR will become a huge PCR, and vitreous is like a tsunami, and the entire vitreous will start coming into the anterior chamber, and you will have a thing. So immediately you need to go bimanual, remove the vitreous first, and then remove the cortex. And what happens to the nucleus? If you have done a lot of karma, the nucleus will come up. Okay, and I have done a lot of karma. You can see how the nucleus will beautifully come up, and that is the way. And normally when the nucleus goes in, you need to go in, clean up the anterior segment and do the pars plana vitrectomy as well, and this is a post-operative patient. If you understand this slide very good, this animation, and that is, the entire ball game is over as far as PCR is concerned. When you have PCR, you have a coaxial irrigation aspiration. Coaxial means the irrigation aspiration are in the same port, and if you do that, what will happen is the PCR will become more, the vitreous will get hydrated, and more vitreous will come into the anterior chamber and enlarge the PCR. But you have biaxial or bimanual, wherein the irrigation is separated from the aspiration. So you can see this in this particular video. Here, what I am trying to say is, this is one of the very hard cataracts, and as I am taking the last piece, there is a post-occlusion surge, because I was using a second generation phaco machine at that time, but I didn't lose my calm at that time. I just removed and I introduced viscoat. The viscoat actually, I don't have any financial interest. The Alcon guys are not paying me a single paisa, but what I am trying to say is, the viscoat goes and plugs that PC tear. Can you see that PC tear is like a small posterior capsular excess? So introduce viscoat, don't allow the chamber to shallow, and gently withdraw the phaco handpiece from the eye. Then immediately create a right side port. When you create a right side port, what will happen is, you create a bimanual compartment. That is, the irrigation is separated from the aspiration, and then you can see that even at the end of it, the beginning as well as the end of it, the PCR size is being maintained very well. Again, during the hydro, it's very important that every time you do a hydro dissection, okay, you need to decompress the nucleus. Why you need to decompress the nucleus? Because you don't want that fluid to go behind and create a what is called a hydro rupture. So this is what happened. You can see here, as I didn't decompress the nucleus. You saw that video, how it opened up the anterior capsule. This capsule is likely to extend across the equator and go into the posterior capsule, and as soon as you put the phaco probe, you can use the thing into the vitreous cavity as well, nucleus. So you can see this is a posterior polar cataract. You can see that as I am trying to aspirate the epinucleus with the phaco probe, I got the PCR. Immediately I injected viscoat, and immediately I put tricot, because I know there is vitreous there. Because if you put tricot, diluted tricot, dilute into 1:3, then you will know exactly how much of vitreous is there, and then go ahead and remove the vitreous first. Don't be in a hurry to remove the cortex and the epinucleus, and that is what you can see here, removing the vitreous and then removing the cortex, and go ahead and put a lens in the sulcus. And you can see again another patient with the PCR. You can see that the PC tear is actually, if you notice very carefully there, it is all the way going. If it is a small PC tear, what is the most important thing is to convert this into a posterior capsular excess, because a posterior capsular excess definitely has got a better strength than a PC tear. This unfortunately was extending from, and it became a radial tear extending into the equator. I was not able to do it, but I was able to maintain that and prevent the vitreous from coming out. But you can see I am putting a single piece Acrysoft lens into the sulcus. You can see what is happening to the PC tear. The entire PC tear start extending. Fortunately for me, the lens was stable and the patient doing very well. Again, you can see the posterior polar cataract is again a very major issue, and you can see in this particular case how this posterior polar cataract, and this patient is actually an ophthalmologist. He came to me and he had a posterior polar cataract and was getting scared to get operated. So what happened was, you can see that this posterior polar cataract, as I am doing the posterior polar cataract, as I am removing the epinucleus, all the slow motion parameters are very, very important. As I am removing the epinucleus, you can see there is a huge dehiscence. Okay, this is not actually a PC tear, it's actually a dehiscence in the PC, in PPC, and you can see that there is like 2 pillars on the posterior capsule. So immediately I go and immediately I create a right side port, immediately I put tricot, because even with the vitreous is a colorless substance, even God cannot see the vitreous without the tricot there. So it's important that you use tricot there. Don't use too much of tricot, because it will go inside and produce a white glow and you may not be very sick. You just use a little amount of tricot, dilute it very well, and that is good enough for you to remove the vitreous. So go bimanual again. But when you put the lens, this multi-piece lens, because there is a huge what you call dehiscence in the posterior capsule, the multi-piece lens, this is an Acrysoft 3-piece lens. Don't leave it in the sulcus. If you leave it in the sulcus, what will happen is there can be long-term decentration, UGS syndrome, secondary glaucoma, all these problems can occur, uveitis. So always lock that optic, that is haptic is in the sulcus, lock that optic into the capsular excess margin. So the lens gets locked, the lens actually, the optic is actually in the bag. You can see this, the end point is the ovalization of the anterior capsular excess margin, or the capsular excess margin at the end point. So this lens will be locked forever, and you can see that it's important that because this lens will not move a micron, and you can see that if you have a what you call a posterior polar cataract, mature cataract in one eye, you can always look at the fellow eye. Look at the fellow eye, because you do not know whether it's a posterior polar. If a fellow eye has got a AC IOL or a PC IOL in the sulcus, or a glued IOL or iris claw, this should give a suspicion. Just to show you, I will quickly go through this. This is the posterior polar cataract and young fellow. This is a mature cataract. The fellow eye had a lens in the sulcus which we missed. So probably we thought, okay, we will go to the femto, and went ahead with the femto surgery. You can see there is a huge dehiscence there. I immediately went bimanual and created a bimanual, and fortunately for me, the vitreous face was intact. But I was a little overzealous and went ahead. You can see what I am trying to do. I ruptured the anterior hyaloid there. Once you rupture the anterior hyaloid, you need to make sure that vitreous is removed. This is the postoperative pictures once the lens is locked. And again, since we are running short of time, I will close here. Thank you again for the wonderful opportunity. The most important thing I want to leave home with your message is the final slide which I want to give you. These are the IOL options: prevention, early recognition, good vitrectomy, bimanual techniques, small PCR convert to PCC, do not pull out, use tricot preservative free, bimanual, no using sponges or devakers, remove the vitreous first, remove the cortex and epinucleus, appropriate IOL, suture the wounds, because the incidence of endophthalmitis goes up when you have vitreous loss up to 4 to 5 times. Thank you very much for the wonderful opportunity.
Thank you, sir. I think that good karma part was missing in that take-home message.
Thank you. Good karma.
Thank you, Dr. Mohan, for
good
the
karma is very important.
wonderful description of the PCR and its management in different situations. You have shown beautifully all the cases.
Thank
so
you.
beautiful videos, sir.